Hello everyone, and welcome back to what will be the last lecture in this series on gram-positive bacteria. So next disease we're going to talk about a mixed class of organisms. We'll talk about our mycobacterium. So mycobacterium colonize in terms of endospore formation, cell wall composition, growth rate, and resistance to antimicrobial drugs are things that we are going to cover. So these are non-endospore forming pathogens. Their walls are a little bit different. They don't have that gram-positive, gram-negative wall that we usually associate or we've been talking about with either the bacillus or the cocci. They have this mycolic acid. So they're chains of carbon atoms that we usually see. This really kind of funky aspect of the cell wall is responsible for the really interesting characteristics that we see for this bacterium, which are slow growth, protection from lysis after phagocytosis, the ability for intracellular growth, and resistance to gram staining. They don't gram stain positive or gram stain negative, although we put them in the category of gram positive. Resistance to many antimicrobial drugs, and also resistance to desiccation. So tuberculosis, it will be our disease that we talk about, and many of you all are probably very familiar with this, considering that we have to have a TB test now as part of your enrollment in our in class. Is a respiratory disease, and it's caused by Mycobacterium tuberculosis. We used to refer to tuberculosis as consumption, the consumption disease or wasting disease, simply because of the way that it breaks the body down. So we look at it growing on the plate. It kind of has a yellowish sort of tint to it. The pathogen is not really all that virulent, considering that only about 5% of people that are infected actually develop the disease. However, it kills about half of untreated disease patients. So if they're not getting any treatment, then it can actually be fatal to them. And here we are looking at this underneath a light microscope, and what you see here are the cell walls of it and its ability to be resistant to gram staining. So we actually use what we call acid-fast staining for this. So the mycobacterium in this picture are those that are pink, since they don't use gram staining for it. So there are three different types of tuberculosis that we'll talk about. We have primary tuberculosis, and then we have secondary tuberculosis, and we also have the drug-resistant tuberculosis. Primary tuberculosis results from the initial infection with the bacterium. Secondary or reactive tuberculosis is the reestablishment of the active area after it's kind of been dormant for some time. And then disseminated tuberculosis is what results from the spread of the TB throughout the body. So the symptoms are going to arise as a result of various different parts of the body that are affected. So we look at the pathogenesis of primary tuberculosis on here. The bacterium will infect the respiratory tract and usually inhale them. And the inhalation of these respiratory droplets from infected individuals, they will then the macrophages of the alveoli are going to try to phagocytize the bacteria, but they don't fully digest them. And the reason they can't fully digest them is because the aspects of its cell, the mycoplasmic or the mycolic acid cell wall, prevent the fusion of the lysosomes to these endocytotic vessels, so you don't have this phagolysosome complex that is formed, that is mode of evading phagocytosis. So what happens instead is that the bacteria is going to be able to replicate inside the macrophage, and it will gradually kill these macrophages that are meant to deal with the infections here. So with the infected macrophage present, the antigen, or the infected macrophage presents this, hey, I'm sick antigen to the lymphocytes, and that produces lymphokinases, which attracts inflammation, and these tightly packed macrophages will surround the area of infection, and they form this nod or this tubercle, and that takes a little bit of time for that to take place. So all of this is happening inside the alveoli. So what we're looking at here is this is the alveoli, and we've blown it up. And then here we're looking at the tubercle, or all of these different infected macrophages, these infected white blood cells that have been tried to fight the infection, but were outsmarted by it, if you will, because the bacteria was able to escape the part of the cell that would break it down. So now they're just kind of, they put these cell surface markers on their surface of their cells and says, hey, I'm a sick cell, I'm a sick cell, so it allows for inflammation to take place, and it calls out more white blood cells to try to heal this area, but they get caught in the trap as well. So that's another way to think about it. Other cells can deposit collagen fibers to enclose the infection in the macrophage. Within the tubercle, the infected cells in the center of the tubercle are going to die, and then as a result of them dying, they release the tuberculosis, and they produce these necrosis, or the death of the tissue as a result. So then we have a point here where it's a stalemate between the bacteria and the body's own defenses that are happening. Now, for secondary or reactivated tuberculosis, this happens when tuberculosis actually wins that stalemate, and the tubercle is going to rupture, reestablishes the active infection, and reinfection occurs in about 10% of patients, especially those that don't have a very strong immune system, or those who have poor nutrition, alcohol or drug abuse, or other factors. So disseminated tuberculosis happens when the macrophage carries the pathogen via the blood, because your lungs are highly vascular tissue, to lymph nodes and to other sites, including the bone, the marrow, the spleen, and it can also even go to the brain. So for our epidemiology on here, cases of tuberculosis in the U.S. are rapidly declining. We mostly see them, it's very common in Asia and Africa. The CDC estimates that tuberculosis may infect more than 9 million undiagnosed Americans, which is one of the reasons why it's part of our new protocol here, that you have your TB test done before you register for classes. 1/3 of the world's population is affected. Multi-drug resistance and extensively drug-resistant strains of tuberculosis are being seen in some countries. So diagnosis, you all are probably familiar with this. You have a tuberculin skin test, which identifies possible exposure to the disease. A positive reaction means that there's an enlarged, reddened, raised lesion at the inoculation site. So in that lesion is usually not just, initially, most people are going to have a raised lesion at first, just as your body is like, hey, there's something new that's happening in here. But by the time the test is taken, especially if that lesion isn't very hardened, then they would not consider that a positive result. However, if it is a hardened, raised lesion that stays there, then the chest X-ray, then you would have a chest X-ray, and they look for the presence of these tubercles in the lungs. So a primary TB infection usually occurs in the lower and central regions of the lungs, whereas the secondary infection is going to happen a lot higher. So treatment, very easily treatable unless we're talking about those multi-resistant strains. Common antibiotics are very effective. Combination therapy used for months to treat the disease, but these are really kind of powerful antibiotics that we're talking about here that we use to treat it. And it's not something that you just take a 10-day course of this antibiotic and it's over with. It usually takes some months to completely treat the disease. So prevention, immunization, with the BCG vaccine, where tuberculosis is most common. So in those places we talked about in Asia and Africa, there is a tuberculosis vaccine that we can use. Avoid inhaling respiratory droplets from TB patients, so making sure that you are not wearing a mask when you're working with TB patients is a way to, as an effective method of prevention. And so over here we see the raised red, and you can kind of see there's places where it's hardened in there. The raised red lesion from the tuberculosis test, and then we have these nodules or these lesions in the chest X-ray. Next disease we'll talk about is leprosy, also called Hansen's disease. It's also caused by a mycobacterium called Mycobacterium leprae. It usually grows best in cooler regions of the body, typically your extremities, not anything that's close to your central core here. The bacteria do not grow in cell-free culture. So we use armadillos to culture them because armadillos are the only known other host other than humans. Pathogenesis of it, there are two different forms of leprosy. We have tuberculoid leprosy and lepromatous leprosy. Tuberculoid leprosy is a non-progressive form of the disease, and it elicits a strong cell-mediated immune response. So it's much more limited. However, although it is limited, it can still be spread and it can still cause different sorts of issues. Lepromatous leprosy is the more virulent form of this, and that's because it will not elicit as strong of a cell-mediated immune response, so those T cells don't respond as strongly to it. We are seeing that cases of lepromatous leprosy are much more rare, and this is the more severe form of it. So this is the leprosy that can cause those different types of deformities with the hands, whereas tuberculoid leprosy usually results in just different types of, there are different spots on the body, on the skin, because the bacteria multiply in the skin and the nerves and it destroys that tissue. That's what allows for the damage to be seen in those extremities. Because remember, they like to grow in places that are cooler areas of the body. And here's a picture of lepromatous leprosy and the severe deformities that we're talking about and the degradation of that tissue as a result of them growing in this area. Because of this very pronounced physical symptom of leprosy, this is one of the reasons why traditionally lepers have been, and it is an absolutely contagious disease, why lepers are usually outcast or shunned, banished, or quarantined throughout history because of these severe disfigurements and the fear of contamination. So diagnosis based on signs and symptoms of the disease, loss of sensation in the skin lesions for tuberculoid leprosy, and definitely the disfiguration of lepromatous leprosy. A skin test can be used to positively identify it with the leprosy antigen. Treatment, combination of antimicrobial drugs. A lot of times lifelong treatment is going to be required. As with tuberculosis, Mycobacterium leprae quickly develops resistance to just one antibiotic, so that's why there are multiple drugs for it for a period of 12 months, and like I said before, it can also be a lifetime needed. Prevention, limiting exposure to the pathogen, and also the BCG vaccine provides some protection against leprosy as it does against tuberculosis. On to propionic bacteria. These are small anaerobic rods that are often found in the skin. Propionic bacterium cause propionic acne. Bacteria causes acne. It's most commonly involved in human infections. We commonly see acne in adolescents and young adults as a result of very active, or what they consider overactive sebaceous glands. Most cases of acne don't require any treatment other than over-the-counter topical treatments like salicylic acid. If you use things like, what's this stuff called? Any of like face washes, a lot of face washes have salicylic acid in it, whether it's Neutrogena or any of those other brands, they're just kind of over the counter. For more severe cases of acne, antimicrobial drugs can help control the growth of the bacteria. All right, so that is it. That's everything we have to talk about for this for gram-positive organisms, and then in our next lecture series we'll be talking about gram-negative cocci and bacillus. All right, have a great morning, noon, or night.